Today I am going to talk on prevention of dumbness. It's a topic which is very dear to me. We are all very empathetic to the blind, but is not dumbness a bigger gravity, a disability? Because what happens? The dumb person knows that he is missing something because with his vision he is able to see it, whereas the blind person does not know what is missing. So if you do not know what is you are missing, then the gravity of disability or the emotional handicap that you deserve or you get is very little. So I personally believe that, not because I am an ENT specialist, I personally believe very strongly that dumbness is a greater disability and needs to be attended to by the society. And what do? We have to prevent it, because dumbness is not curable, it is only preventable. And what is the gravity? There are more than 1 in 1000 newborn babies are likely to become dumb. So I am making an effort to sensitize the society on this grave disability so that we can prevent dumbness. And why it is important? Because we cannot cure dumbness, we can only prevent dumbness. Now what is dumbness? Dumbness is nothing but lack of speech. They say man is a social animal. So you don't have speech, you become an animal, because only man has verbal communication. And we all born dumb, but we learn language and we get our speech in due course. It is the absence of this learning which continues to make us dumb. So in short, I strongly believe that if there is a person who is dumb, the society has failed, because we did not do what we should have done to give this child a language of speech. Now that we understood that all of us are born dumb and we develop our language and speech, what have we to do to prevent it? As I said, dumbness is preventable, not curable. Or in other words, speech develops when we have certain inputs at a certain stage. The most important activity which the society has to understand is the gravity of the situation. Number 2, early detection, to find out this hearing loss as early as possible, and then intervention to develop the language. We have to do a lot of things to develop the language. So early detection is most important. The early intervention is the next. Now unless we do this at an early stage, that's why we have newborn early detection. So we should try to get these children who are hard of hearing at least before 1 year. Then the child will go to a normal school with a normal speech if we do the intervention correctly. It is the delay which makes these people or these children to continue to be dumb. Speech is one of the most difficult activity in a human being. Only human beings have speech. You have birds, they have language, but their communication is through some type of sounds. It is rarely because of speech. Articulated words, very, very rare. Only human being has. So it's a very complicated activity which human has developed. And to understand and prevent it, I think the society should understand every details of how a person speaks or how he or she develops speech. The most important is to understand what is learning. Now when we talk of learning, there are a lot of descriptions given in the books, a lot of descriptions, most of them are with respect to the response or the activity as to what learning achieves. Exactly what is learning is very simple, because it is nothing but software, like the software in the computer. Once the software comes, the computer will start responding. But if there is no software, the computer does not respond. Same way, if we have learned, that means we have learning or we have the software in our brain, then we will respond. So learning is nothing but software. And unless we have the software, the speech which is an output of this learning, we will not have. So in my talk, I am going to use the word language for this software which is related to speech. Now what is the speech related software? Understanding of verbal commands. When I give a command, simple verbal command also, or a complicated verbal command, and you can understand it without the action, then it is called speech. And the software which helps you to understand that speech is language. Now we understood learning is nothing but the software in the brain. Now this software has to be developed in human beings. It cannot be loaded like a computer. That is why in human beings, different people have different varieties and different types of software. It's not the same quality of every human being. Whereas in a computer, there is just say Windows, or you talk about operating system, iOS. It is the same in every computer or every phone. But in human being, it varies. Now, how does the human being develop this software? Now, you have to have an input device, like in a computer, you have to have an input device to load that prepared software. There the software is prepared out, but in human beings, what we do, we give information. And how the information is reaching the brain or reaching the human being is through the 5 special senses. So, why it is called special senses? You see, in India, even in our old scriptures, it is mentioned 5 special senses, Indriyangal, Anju Indriyangal, 5. So these 5 special senses are called special senses because it is only through these 5 organs that you can give input to the human being. This input is developed or processed by the brain exactly like we develop a particular process in the computer. Number 1 is we call processing. The information that the patient gets, he makes a sense of it and keeps it in a place. Then when he gets the same information again, that particular information is made a sense, is a meaningful information. And then he does the correlation with different activities. And then the output comes. The output is speech. Now I like to clarify it by simple example. Mother calls a son. The son hears there's some noise, some voice, and he makes a sense of it. The mother again calls, and then the son sees the mother. So he correlates, okay, this voice is coming from this lady. And who is this lady? He correlates as initially as a person, then subsequently as a mother. Next time, when the same sound is heard, even when he does not see the mother, he immediately says, oh, my mother is calling me or mother is talking to me. And you will find the child smiling. So this processing, integration we call the other one, that you integrate the different things. All this process is the development of the software. And once the software is developed, it is the output of the software which is speech. I would like to again emphasize that speech is the output of a software which I call language. Language is understanding of verbal commands. That is speech commands. Now, how does this speech develop? It's very important for you to understand this because our complete program is based on understanding this particular area. Now, like in a computer, we have an operating system. Without an operating system, the computer does not work. Either Linux or Microsoft or whatever operating system you have. So, the operating system is the base operating system. Similarly, in speech, we have a base speech. This base software called language, in a human being, till 3 years it develops. Or shall I say 95% of the speech develops by 3 years. After that, after 6 it's impossible to develop, or 5% develops after that. Now what happens is, suppose I do not do anything to my child, then take this child to the doctor at the age of 6. The child, we cannot develop language even with aggressive intervention. Even with aggressive intervention. Why? Because it is like without an operating system in the computer. Now, for example, tomorrow you learn Telugu. How do you think? You don't think in Telugu, you think in Malayalam or whatever your base language is. Like I am a Malayali, so for me, I think in Malayalam whenever I talk in English also. Similarly, it is with the base language that you develop the other language. And this base language, a child develops till 3 years, 95%. And only 5% after that. In other words, after 6 years, you cannot develop at all. And you want a good development, you have to catch the child at least by 6 months or 8 months and start intervening so that the child can develop language. And once the language develops, the speech comes. So the most important activity by the society should be to detect hearing loss at a very early stage. And why it is so difficult to detect? Because hearing loss, unlike other disability, is an invisible disability or a disability which you cannot see from outside. I'm again repeating, 95% of the base language which is mandatory for you to develop speech in a child develops by 3 years. After that, it is very, very difficult to develop language, and you cannot develop language after 6. Hence, the most important activity is to detect the hearing loss as early as possible. Now, the patients I am talking is those patients who are otherwise normal with only hearing loss, which forms majority of the people with delayed speech. We are not today going to talk on those children who have a learning disability or who are intellectually challenged, who form a very minority compared to the majority of the children who have only hearing loss as a disability and who can be habilitated or who can be sent to a normal school. Now that we have come to an understanding that we have to detect early hearing loss in children. What is the number I said? 1 in 1000, which I thought telling you is a very huge number. 1 in 1000 is not hearing loss. It is those children who will become dumb or continue to be dumb. I think that's a better word to use. Continue to be dumb if we don't intervene. 2% is the number of children who have a hearing loss, but they may not become dumb. They will delay speech and all that type of activity. So what the WHO and the health givers are doing is they are doing a newborn screening. It's called a universal hearing screening of newborn babies, which is done in many hospitals. Now I have found people who are having resistance to even do the newborn hearing detection. I can't understand why, because the test they use is a very simple test called transient evoke response audiometry, or distortion product autoacoustic emissions we call it. We detect that emissions. Now it's a simple test, you just put a probe in the ear, after 2 or 3 minutes you get the test. So why people are reluctant to do it? I have not understood. And it tests hearing, it doesn't test hearing loss. That is the small drawback of it. So when we do this, newborn, a child is born, you do the test. Now once you do the test and it is showing good hearing or the test is positive, then we know our child is hearing normal. I am discussing this OAE test which is done at the bedside, newborn. It's a harmless test because of sound echo. It is not even a current based test, it is a sound echo. Takes only 2 or 3 minutes, done by a semi-trained person. And you get huge information. What is the cost is negligible compared to the benefit, because if unfortunately your child happens to be the child with a hearing loss and he becomes dumb for life, that family is wrecked, not only that patient. Throughout life the child is suffering because of one disability which could have been detected and corrected or the language developed if with proper intervention. So my advice or request to all of you is every newborn child should undergo this OAE. I am again saying OAE. It is a newborn bedside detection test for hearing. It detects whether the child hears or not. So everyone should do this OAE test and confirm the hearing in your child as early as possible. Now what is this test? There are different methods by which different centers do. What the method we are doing is what I am going to discuss. Okay. So OAE, newborn baby, we detected hearing in about the false negative we call, that is those children who have hearing but it doesn't show in the OAE, is around 15% or 20% depending on the type and place of. So let's work on 15%. Now 15% of the children are labeled as negative. So what do? Do we label them as hard of hearing? No. Now these children, we have a repeat check when they are 6 to 8 weeks. After 6 to 8 weeks again negative, then we have a final checking at 3 months age. At 3 months age, the final checking is done and you find all tests are, we call it refer, we don't call it negative, because actually the child may be having a normal hearing. So positive is good if the child does hear, because it's a hearing check test. It is not a hearing loss check. Please understand, hearing checking, not hearing loss. Now once the hearing check is positive, that means the child is hearing normal. If it is negative, they may have a hearing loss. So that may should always be kept in mind. And as I already told in the beginning, 1 in 1000 patients only have hearing loss, whereas negativity or refer in case of OE is up to 15%, that is 15 out of 100. So then most of them will become positive in the next test or the 3-month test. Now those people who fail all the 3 tests, that is the first newborn, 6-weekly test and the 3-monthly test, we put them into the intervention program. And this is an intervention program where the final confirmation and other activities are done. So detection is where I want all of you to understand the need. Number 1, dumbness is preventable but not curable. The most important activity is to find the hearing loss early. There are beautiful universal tests available today which can detect a hearing in a newborn. Please make use of it, or take your child to a center which has this facility and get the hearing checked and confirmed of your child to prevent dumbness or to detect hearing loss and prevent delayed speech. Now, what about a person who, for whatever reason, could not get his child checked, or there is no facility nearby and he has no facility to go to the hospital and get a newborn hearing screening test or the second screening test? The best is for the parents to be sensitized on the fact that my child may have a hearing loss. Now, how do you make out whether my child has a hearing loss or not? Generally what I hear my patients coming and telling is, sir, kai kuttiyal. That means if you clap the hand, the child responds. Or when the thunder comes, the child startles. Please remember, those are startled reflexes, they are not hearing reflexes. The hearing reflex is the one where a person responds to a meaningful word. A meaningful word, I am again repeating, not just any sound. Meaningful word. It's a very common mistake that a response to sound is considered as normal hearing. No, that is a startled reflex, we call it. It's a reflex. It is not actually a response which comes from the brain. The response which comes from the brain is when there is a meaningful sound. Meaningful to whom? To the child. Meaningful to the child. I am again repeating, meaningful to the child. Now, what do you mean by meaningful to the child? Like, for example, there is a child who calls chocolate Lala. So when he sees chocolate and says Lala, it's a meaningful word for the child. But it's weak scold, not this thing, it is chocolate. You say chocolate, others will not give you chocolate. Please don't force the child at that stage. Now, a normal child, now how do you think the response should be? Normally they call babbling. The first speech effort by a child is babbling. And babbling, there is a spontaneous babbling which starts by about 3 months or so. So many parents think, oh my God, my child is normal because babbling has started at 3 months. No. If it is spontaneous babbling, after about a month or so, it starts dying out. Whereas if the babbling is due to hearing and the language development, then what do? This babbling will continue and it will become more aggressive till they come to words. So when a child has about say 10 months or 12 months, has about 10 words, meaningful words to the child, I am again repeating, the child meaningful words, whereas where he calls Lala for a chocolate, but he doesn't call a phone at Lala. So a child who has about 10 or 12 meaningful words by 10 months or 1 year, we need not worry at all. But if it is not that, then we have to worry, get checking done. The other scenario is simple verbal commands. Son, come here. Or will you come for milk? Or mom, call mommy. Simple verbal commands. That if the child is responding, that means not with action, come here, no, come here. So simple verbal commands, child is responding at the age of say 5 months, 6 months, 7 months, or other simple thing like mother is stirring the milk and suddenly the child starts hitting his hand, starts smiling because he knows he is going to get the milk. Or he is sleeping and the mother's voice comes and suddenly the child starts smiling. So these are things which the parents can note, that is response to speech, response to verbal command. Simple responses you see. If you find deficiency in that, immediately you should get the hearing check and go to an intervention center. So detection everyone is doing, and there are a lot of people who are encouraging, but the intervention is where the activity needs to be increased, and we have to more focus on intervention part, because intervention is very difficult, plus it's a long drawn out process. You have to be technically very good to really give good intervention. Now what is the intervention? In intervention what we do is, there are two main aspects. One is the institutional I call, where you go to a good center and get it done. The second is non-institutional. I'll go give the details one by one. One is the institutional, second is the non-institutional intervention. The institutional intervention again has two main aspects. One is the hearing loss part. What do? We first confirm the hearing loss, we quantify on the type of hearing loss and how much is the hearing loss, and the second part of that is to fit a hearing aid to compensate the hearing loss. Why I said the word hearing aid is because normally a child to continue to be dumb has to have profound or at least severe hearing loss. So severe and profound hearing loss you cannot cure, because normally due to sensory neural or nerve deafness in layman term, so we can only compensate the hearing loss. So the institutional part is detecting the quantum of hearing loss or identifying or quantifying the hearing loss and then fitting the hearing aid. Both are very difficult and needs to be done in a very good center for reasons which I will be discussing in due course. The second is non-institutional. In non-institutional is, the first part is the auditory verbal therapy, where we give therapy to the child. The second is to include them into the normal. There is a tendency among people to isolate these patients. No, they should be taught in a normal school with hearing aid naturally and with support from the therapist or the setup which is doing the auditory verbal therapy. What is auditory verbal therapy? Again I will be discussing. Now that I have given an idea on the intervention, and it's a long drawn process, because 3-4 years it will take for the child to develop normal speech. You see, a normal child with normal hearing also takes about 2-3 years to come. So the child with challenged hearing will take longer. So during this long period, I am again of the strong belief that there should be a master who is a controller. I would prefer the ENT specialist or the physician, the general physician, that is general practitioner, the family doctor of the patient, or a pediatrician to be the band master, I'll call it in layman term, so that they can coordinate at every stage when the parents are losing, or the audiologist is failing, or the therapist is failing, so that supervision. So one of these, that is the ENT specialist, the physician, general physician, or the pediatrician should take responsibility, or someone very dear like the grandfather can take the responsibility of the grandchild, or someone caregiver who is accountable to the activity and the development, and who can probably put his pressure on the parents or the care supporters to achieve good result. I have already said there are institutional and non-institutional. First let us talk about the institutional. The first is confirming the hearing loss. The second is quantifying how much is the hearing loss, and then the hearing aid fitting. So the first part is done by the audiologist under supervision of the ENT specialist, or if a ENT specialist is trained, probably he himself can also do it, but the audiologist helps the ENT specialist. Now what is the problem we face? Because this is a prelingual child, a child who does not have language and who does not have speech. So we have to make assessment based on our experience to find out the hearing loss. So what we do is, we do a totality approach, not a single test. Okay, one test shows this, so it's a hearing loss. No. There are multiple tests which we do, and then multiple clinical assessment. Like the mother says, the child hears because when I say something, the child laughs. Then you check up when the child is standing in the side, whether mother is standing in the side, and then the child is laughing, then of course it goes in favor of the child hearing. So a totality approach, no single test, and even in the best of centers in hand, we have found things changing. There are occasions when I have found that I found this child to be having so much hearing loss, but after later stage we realized no, the hearing loss is not so bad, or vice versa, that the hearing loss is very bad compared to what we had initially. So it's a continuous process of evaluation. The feeling that people have is like we take a CT scan and the whole image is there. No, this is a mixture of tests, because most of the tests, some are fallacious in some way, some are fallacious in some other way. So a totality approach is what we have to take. So first thing, parents, caregivers and doctors who are involved with the child's welfare should not put pressure on the audiologist or the team which is evaluating the child. In the evaluation process, we call it the gold standard. The most important test is what we call as an ABR test or a BERA, Brainstem Evoke Response Audiometer. So that audiometry is a computerized test where we make the child, put the child to sleep and then do a test. It takes about 1 hour each test, and that is the literally very reliable standard test, because the child does not respond. So based on these tests, BERA being the gold standard, we make an identification or quantification graph and decide, okay, this child has so much loss approximately in so and so frequencies, and then this is given to the hearing aid fitting team. There is a feeling among people that hearing aid fitting is a joke or something very simple. The most complex energy is sound energy. For example, in the specs, press minus astigmatism, 3, that's all. In hearing, there are so many of parameters that it's so complex. Now this complex energy, first to understand the complex energy, number one. Second, the hearing aid. Hearing aid is a very high-tech equipment. To understand the hearing aid and then match the two correctly so that the child can get the correct amplification is not only just a theoretical but very difficult practical challenge, especially in a child who cannot respond and tell you whether the child is hearing correctly or not. Just imagine the difficulty a audiologist or a hearing aid fitting person takes or undergoes to fit a hearing aid. Now let's talk on the hearing aid itself. What is the range? See, there are hearing aids available from about say 1,000 to 3.5 lakhs. So what is the difference? The difference is the quality of the hearing aid. And what is the mean by quality? The amplification of speech with respect to noises. So first point that the parents and caregivers have to understand is to find the budget to give a reasonably good hearing aid. I have patients who come and says, sir, initially we will give him a low quality hearing aid. If there is adequate response, then we will give a good hearing aid. It's a misunderstanding. Why? It is not like cycling that you buy a bad cycle, he practices that, he falls 5-10 times and the cycling activities become okay, then you give a good cycle. Here, unless the patient can be given hearing, which in turn will be listening, and he will develop the software. So if your inputs are going to be more noises compared to speech, how do you expect the language to be developed and the speech output? So initially try to give as much as you can afford. If you can afford 1 lakh, go to 1 lakh a pair. So the first point is try to give the maximum, not the minimum. I know if it fails, the hearing aid programming and then the trial, it fails, that's a loss. But the loss is very less compared to what you are going to save. Because you give a poor hearing aid and the child does not develop language, will make him a cochlear implant patient. And cochlear implant, even the worst cochlear implant costs around 8 to 9 lakhs. And a good hearing aid, 1 to 2 lakhs, you will get a good pair of hearing aid. So purchasing a good hearing aid is the first need, which the parents and the caregivers have to understand and find a way for it. The second is of course the audiologist who makes effort to program it to the patient's need. Now here there are 1 or 2 very important points where the parents have to be fully cooperative, because at the first instant the hearing aid is fitted based on the computer parameters that we have got. So what do we do? It is an approximation with which the audiologist is programming the hearing aid. It is not the correct. Now as the child starts developing language and responds to speech and starts speaking, we will get more information and then we give readjustment. So every 2 or 3 months readjustments have to be done. There are many ways to do it. We in our center do a thing called a link test, Daniel Link's test, 7 sounds test, that is given in the computer and you can see it in the internet. And there are many other ways, but the point I am trying to insist is the parents should not think first day fitted and the battery is over. No. Fitted is only first part. Then as the progression occurs, the reprogramming has to be done. And for that, parents should not feel frustrated at I have to come so often and still the parents are, no, please no. You have to have a lot of patience to help and be, actually you should become a friend of the audiologist, friend of the ENT specialist, and you all should combine to help this child come out, develop language and then speech subsequently. Now that first detection is over, we have started the intervention, and the intervention, the quantification is over. Now we fitted the hearing aid. Now another very difficult part is coming. That is to teach the child to develop language. It's a very, very unfortunate that many people think speech therapy is the answer. No. Here the child has not developed language or the software of speech. Why? Because he did not have the input for hearing. For speech, what are the 2 main inputs? Hearing and vision. We all have little lip reading, that is what we do by the vision. But the main is through hearing. And the hearing has been denied, hence this child has not developed language, and because the child does not have language, the child could not come to the speech stage or did not develop speech. The most important part is to train the child to hear. We call it listen, because the next stage, hearing is an activity which comes in the ear, which converts the sound to electricity. This electricity goes to the brain. The processing is done in the brain. That is what we call as a listening. So it is called listening therapy by some people, mostly known by auditory verbal therapy. Auditory is hearing, verbal is speech therapy. So we have to give these children auditory verbal therapy, not speech therapy. I have seen patients who come and fight with us telling, without speech therapy, how can you give speech, develop speech? You cannot develop speech without speech therapy. So they fight. They say, we want speech therapy. We don't want auditory verbal therapy. So please understand, here speech is an output of language. The language develops based on hearing 90% and 10% through vision. So we have to give auditory verbal therapy or therapy to listen, hear. Now there are some modules which the audio verbal therapists or the speech therapists who are trained to give auditory verbal therapy also go through, and they have the modules. But the problem is, this should be 24 hours therapy. It is not. So tragedy is when the parents will come with lot of difficulty because they have their problems. They'll reach the therapy center. They'll 1 hour therapy session. Effectively, it will be 40 minutes. And once they go back, they don't do anything about it. So in a month, if you have say 5, 6, 7, 10 therapies, it's only 10 hours. Out of 10 hours, you cut off another 15 minutes for the child becoming normal. So how many hours? You get in a month, 6 or 7 hours of therapy. No, it's a 24 hours therapy. Like simple things, what I tell my patients, parents of my patients, is first, keep speaking to the child even if the child is not responding. Like I tell the mother, you're cooking, but keep speaking to the child. Second, keep a radio, something which keeps playing music. Now, music means speech, that is voice, melody voice type of, or where speech is not music in the sense the present loud music or the bass, not that type of music, not the English type of music, but where words are, during our times it would be melody queen words. So where words are being spoken. that type of music or speech, some news or something where the child can keep listening and make sense. I tell the father that you come back from the office, take the child to a crowded area. Just carry the child, don't do anything. Say go to the mall, go to the railway station, go to the bus stand. The child will keep hearing and finds the input, because you have to give extra input to this child. A normal child with normal input, normal hearing will come with his first word only by about 10 months. So this child who has a challenge, who has given a hearing aid which is not the topmost, you have to give lot of input. So increase the input. Don't expect immediate response. So auditory verbal therapy is nothing but listening therapy to make the child listen 24 hours. Second, what the audiologist has done, or that is activity which is, keep repeating that, sometimes mother, sometimes father, sometimes some friends if they have well-wishers, or grandparents, whoever are the child's caregivers, well-wishers, they all should be taught how to give those therapies to the child. So it's a listening therapy, and as you increase the listening therapy, the child will develop language, and once the child develops language, the output of speech will naturally come. Not speech therapy, because while doing speech therapy, the greatest problem is maybe you learn 2 or 3 words, and the therapist may be telling you, oh, Kanda, the child is learning 3 words, speaking now 4 words, but those words will be lip driven, like papa, it will not be papa, amma, it will not be amma. So these words have to come from inside. The language has to develop. How I tell my parents is a very simple thing. You don't know, you're not singer, you never sang, but you have a very good voice. Someone tells you, why don't you sing? There are 2 ways of doing that. One is go pick up 2 good songs, practice that and go and sing that. The other is go and learn the fundamentals and then come and sing. By doing the second, you need more time. You will take more time to learn the fundamentals. But the depth of your song will be very good. Plus, if someone requests you to sing some other song, you will be able to do it. Similar is the auditory verbal therapy and the speech therapy. Through speech, lip reading or speech therapy, we call it oral therapy also we call it. Very few words the child will pick up faster, but then it will stop. So please avoid lip reading or speech therapy. Only do auditory verbal therapy or listening therapy, so that your child can ultimately go to a normal school with a normal speech. Final important thing is to see that my child with a hearing loss or a hearing deficit, whom we have done intervention, should go to a normal school. We call it inclusive education. It is a right even as per our Supreme Court judgment. So include means, this has 2 advantages. One is, our aim is not to isolate these children to deaf and dumb schools. Our aim is to integrate them to the normal people. And if good effort is done, I think today's 90% of the children who are in a deaf and dumb school would be going to normal schools. If all of you join me and we do an effort, even half effort, I am sure most of the children can come to a normal school. So inclusive education should be the gold standard. We should not think of putting the children, because they have a hearing deficit, in a challenge school, because every other 4 senses is in excellent shape. The brain, the computer is in excellent shape. It's only a hearing deficit which you are neutralized. So normal school, normal school, normal school, inclusive education, inclusive education, inclusive education. This is my request to all the society in general, the caregivers, the well-wishers, the parents, the doctors, the ENT specialists, anyone who is interested or who has a role in the upkeep or the quality of a child should definitely think of inclusive education. After we have met what we already discussed, early detection of hearing, early intervention, then auditory verbal therapy after fitting a good hearing aid, and then finally inclusive education. So we give our children good hearing so that the child can develop a normal life with normal speech and not be relegated to animal status, because that is the only difference between human being and animals. Animals do not have verbal language. They have language. Through sign they communicate, but verbal language is not there, only human being has. So we should not relegate them to an animal status. The purpose of this talk is just to stress this last final point.